What you guys should have done is wore dresses, so under the desk it was a little mismatch.
Yeah.
Well, I told Alex about that, and he's.
What's here?
I'm done on that one.
Yeah.
I think
We missed 2 rounds of random commentary because of technical difficulties, which something's getting launched into the stratosphere after this, whether my camera or microphone or something. We got first appearance by Tanner Zimmerman.
Yep.
Zim, the man.
Z-Dog.
Zoom.
I'm not introducing these dudes. We were just saying some reptile left out cheeseburgers that were just made.
Look, dude, he said reptiles. If he had said anything else besides that, probably maybe.
And we were having a conversation about movie foods that seem like there would be no way they'd be as good in real life as they would be in the movie. The fluff from the food fighting hook, right?
Mm-hmm.
Oh, Peter.
Banger.
Yeah. Butterbeer, candy off the cart.
Yep.
And then color crappy
Color movie stuff. Or any pizza
Yes.
off of the pizza review.
Crab pizza.
Well, I'd say Teenage Mutant Ninja
Yeah, I was gonna
Turtles.
say Ninja Turtles.
Yeah, for sure. Yeah, there's no way it's that good. Anyways, I'm not presenting a case today. I'm color commentary. So it's Tanner.
Yep.
This is probably where people shut things off.
These 2 cases. Oh god. Gosh. So we're also looking for more reviews of the weekend review. Please leave a review after this episode. In particular, mention Seth and Alex.
1 stars only.
You don't have to mention me.
No, I looked to see if we had any new reviews because we just started this back up after like 3 years or something. Yeah, something like that. And our last review was 2 years ago. So bring them in. Who's up first?
He's up first.
I'll go first.
Yeah.
I figured we'd let the new guy go first.
I feel like we'd let you go first because I'm gonna stumble through mine since it's the first one. I
That's
got
why we're in a clean finish. You're up.
all right.
It's like wine.
Are you telling me that I would be a rough finish?
You said it. So you're gonna stumble through. Much like you're gonna stumble through the trail tomorrow.
Yeah, because I got
Oh,
stumble through the trail tomorrow.
the trash talk.
When you're
Seth and I are doing an 18-mile run tomorrow. Tanner's doing the 9-mile version. Alex is gonna be contemplating life back at tent.
The storm's gonna be brewing out. I'll hold the tent down.
Is this what's storm tomorrow?
Oh yeah.
No.
And then his legs gonna go numb.
I'm pulling a Lieutenant Dan. That's me at the top of the mountain. Alright, you're
One
upset.
of us gets struck by lightning.
If it gets me out of that second lap, I might be a fan of it.
Just hits you and shoots you to the finish. You finish that in record time.
Hotter than hell.
Burnt to a crisp. All right, so it's first time presenting, so my voice cracks. It's typical.
Just get that out there.
Just go ahead and put that out there. All right, no comments on that, which I'm sure there will be. So I have a patient. I guess I've been seeing for a little over a week. He's a 47-year-old male. He's a firefighter. He kind of goes around teaching like CPR, cardiac triage to like first responders, nurses, physicians, things like that. So he's a pretty active guy. He's also a pretty large individual in terms of just like pretty muscular. So kind of get your physique down. I could stand behind him and he wouldn't be able to do that. But that, like he said earlier, that was like a piece of dust. So, but he came in because he had a 3-month history of having a right-sided neck pain that he feels kind of out into his shoulder blade and then down kind of the medial part of his like scap. So yeah, he got an idea for that. He said he felt it after he had a long fire. This was about 3 months ago. Typically, like he said, fires are like, just a couple hours. This one he said it was around like 8 to 12 hours. And he said they were kind of having to crawl around a whole lot. So he's like on the floor, kind of hooked up an extension. He said it felt his neck was not great kind of from the get-go there. He said it kind of got worse there. Stayed about the exact same. And then on July 4th, he went tubing, and he goes, I typically don't tube. I normally just drive a boat, which most of us here just drive a boat. It's kind of our goal here. But when tubing on July 4th, he said that next morning he woke up and he was in like pretty severe pain, which I guess it wasn't bad enough because it took almost 10 days to get in. The night before he came in, he said he couldn't sleep because it just kept spasming, and he's like he could not get comfortable. I think he said he was up at like 2:30, and that was like the last I think he had like maybe an hour total of sleep all night. He reports feeling some pain about 2 years ago, just like similar pain on the same side. But he also had 2 shoulder surgeries on the right side and then one on his left side. The right side, the last one he went in for, he had a partial shoulder replacement where they took off like the humeral head, placed it, cleaned out the glenoid fossa, and then just reattached the subscap. So yeah, but he said after the shoulder replacement, he didn't feel the neck pain anymore. So he was getting treated for neck pain for about like a couple of weeks by a local chiropractor just down the road, had shoulder surgery, and then had no neck pain. So I feel like that's kind of something important maybe to mention. Yep, so no other surgeries, doesn't wear glasses. The other thing is that he's on 3 blood pressure medications, ADHD medication, and on an estrogen blocker.
So what's he on an estrogen blocker for?
So I asked him about like his free testosterone. He takes it because he had low testosterone.
Okay.
And he said his like free testosterone was like 48, and he's like now up around like 600. But he's also about 6 foot, about 225. He's a pretty jacked dude.
Pretty stacked.
He's pretty stacked.
That's a weird route to get. I mean, yeah, it's a little strange.
I probably should have dove in more on the 3 blood pressure medications as well. That's probably just an overload of blood pressure medications. He doesn't know why. He said he's been on like since he was like 20, about 25. He's been on the blood pressure medication.
So the blood pressure medication came before the hormone.
Mm-hmm. He said his granddad and his dad have had blood pressure issues. And he said he went in about when he was like 25, he was like 140 over 90 is typically what he always registered at. So he got put on a blood pressure medication then, and then he's added 2 more since then. So that's where we're at with him.
Cool.
But yeah, so I didn't watch him walk. I guess I should have, but it was an upper extremity complaint. But I'm not saying that it couldn't have been, but
Sure, walk on the same.
I could have. Hands in. But during my exam, orthos, max femoral compression, shoulder depression, and distraction, they were all positive. I guess I should have started with top tier. Let's go with top tier first. So top tier, he was dysfunctional and painful in a lot of things. Cervical spine, all of them. So extension, flexion, left and right rotation, right upper extremity pattern 1 and 2, and then multi-segmental extension. All reproduces neck pain. Dysfunctional, non-painful, he had left upper extremity pattern 1 and 2, single leg stance on the left, and deep squat. And then functional, non-painful was only multi-segmental rotation right and left, and single leg stance on the right. Which I don't know how, but he absolutely crushed rotation. Tanner was there, and I mean, he like rotated like it was.
Yeah.
He spends more time, I feel like, in the transverse plane than anybody else here. Like that's how he looked, if that makes sense.
Yeah.
Yeah, so that's where we were. So then sat on the table, exam, orthos, like I said, max femoral shoulder depression, distraction, all positive. Since he was on blood pressure medications, I kind of just ran through just some TOS stuff as well to kind of rule that out. So Adson's, costoclavicular, all those for TOS, negative. Breakout, cervical SFMA, he's functional, non-painful, except on extension. So when you passively have him do anything, or he's active laying down, dealing with only his neck, he can pass all of them except extension. And then
There's a passive extension.
yeah, so the SFMA breakout, if you just lay somebody on the table, you just let their head drop off, you try to see if they can get within like 80 degrees or kind of like chin almost parallel with the floor. And that's the only thing he can't do.
Did that reproduce?
Nope, did not reproduce his pain either. So nothing I did with his neck reproduced his pain, laying down, supine or prone, or really anything. Even though it was on like standing with the top tier. So yeah, then went through, checked passive range of motion. Like I said, he was pretty solid on anything like rotation wise. And then flexion, he could get his chin to his chest if I passively took him there, but then extension again, he couldn't. And he's on the seated scan, he's just limited, I say just, he's limited pretty severely in TL extension, thoracic, CT, and then left lateral flexion. So left lateral flexion, right lateral flexion was the one that was kind of limited, but it's also maybe like first rib as well. That was pretty springy. You go off palpation, so right upper trap has just like increased tone. I wouldn't say like there's trigger points yet, but I mean it was right upper trap and scalenes. Basically, you kind of like bounce a quarter off both of those, and they would go ricocheting all over the place. Again, CT thoracic extension restriction, first rib on the right side has like 0 spring, but I also can't really tell if maybe that's just due to like the muscle tone that's there, of why I can't really like palpate through it, but that's kind of my assumption of why it came. But again, there's like no pain that I'm reproducing, even when I take him through like lateral flexion on either side. So even though he had max femoral compression, that was positive. If I like laterally flex him and extend him, he has like no pain. So it's almost like if he actively does anything where he has to turn his head, that's when he starts getting pain. But then I started going back through and started just, I guess, in the back of my mind. Well, I guess let's continue. So I basically came down to the functional audit of having total upper trap in the right and scaling CT thoracic extension. So I did a little bit of like ART, just to like calm down some of the upper trap, scalenes, and then some suboccipital stuff to see if we can maybe clear that up. And then I did retractions as well for CT to see if we could clear up any of the like CT restrictions for extension. So I did all of that. And I would say I'm probably 40 minutes into maybe this whole visit, and he makes absolutely like 0 change. I've made like no progress on anything. He looks at me and he's like, I've got to teach a class right after this. He has to go, he's right across the street. So like I would basically just go watch him if I wanted to out the window and just watch him be in pain, teach people how to do CPR. So that'd be awesome. So I'm sitting here kind of like, I don't know, on the point of sweating. Like I'm fixing to send this guy out of here with not knowing why he's here, what his pain, or I know why he's here, but or like his pain, what I'm going to send home with, and make even a change at all. And I'm also trying to make sure that he kind of like maybe stays a patient with us, because the chiropractor he typically goes to is out of town. So this is where we're at. So then I start running back through just again my top tier. Like I even like pause and go back to my computer because I'm like, I need to take a second look at this. So I go back through just like looking at his shoulder, right? So in his history, he mentioned that he had neck pain previously, had a shoulder surgery, neck pain kind of went away. He went through PT for a little bit. They said I stopped going to PT because I feel like I didn't feel like I was getting any progress. And then he goes, I kind of stopped doing my exercises. Well, then I kind of lay him on his back again, check his range of motion. External rotation, he probably has like 70 or 80 degrees of external rotation. Internal rotation, he's probably got like 20 or 30 maybe. I mean, it's pretty invisible if I had to say the least. But again, we mentioned, like I think we talked about it, like how much range of motion you're going to get after a like shoulder replacement. You know, it could kind of vary on whether you're getting all of it back or that's pretty much what you're going to have for the rest of your life. So I kind of just, since we were there, I played around with it. Is this actual just like a neurological barrier? Because whenever I took an external rotation, his bicep kind of kicked on. And I was just like, just trying to relax as much, for me. And he was just like, I am relaxed. He goes, I don't know why my bicep keeps turning on. So I was like, maybe it's just like the neurological barrier is kind of what we're hitting. So I just did some little PIRs, just to see if we could get any like range of motion increase. And I could basically, I think I had him do like 3 rounds of just like pushing it into rotation. I think I got his external rotation opened up to probably like 100 to 110. And then internal, he got probably down to maybe like 30 or something like that. So I mean, we're opening it up. And when you also take him back through his external rotation, you could feel like it wanted to like almost like vibrate. I don't know how to describe that. Like it was like the body wanted to like stop it, but then it just kept going. So then, like I said, I went back through his shoulder exam. Apley scratch was positive, which we saw that through the right upper extremity pattern 1. Everything else was negative. Radian, median, ulnar nerve tension, no pain, but there was like neurological tension on both sides. I also remember him saying a multi-segmental extension. As soon as he put his arms up, he was like, yeah, I already feel it in my neck. So I was like, okay, maybe that could be shoulder, maybe I don't know. So I just took him through just doing my duty of doing multi-segmental extension. Active flexion and abduction on both sides are painful, but they're not painful if I kind of just help like guide if I pull his like kind of scapula down and kind of help him guide it in upper rotation. He has no pain, doesn't reproduce any of his symptoms either. I lay him supine. I pin his right rib cage down. Or I told him just to like abduct his shoulder while we're like side supine. He's supine. He has pain doing that. I just pin his rib cage down because I'm just like, all right, let's just see if we can maybe change the shape of his rib cage. He goes into abduction again, no pain. So I was like, all right, that's kind of something I should maybe take into account. So again, my functional audit, it came down to tone of upper trap, scaling, CT thoracic extension, and then right shoulder external and internal rotation. That's kind of my 3 that I'm going after. Pain audit is the orthos that I mentioned above, active flexion and abduction of the shoulder. That's kind of what I'm going off of. Diagnosis, I basically like, again, ICDs, I didn't really know how to put this down, but I have like derangement of CT, maybe a brachial plexus traction or something like that. That maybe just getting caught in the scalings up here. But kind of thinking more so just how he uses his shoulder, neck, upper T-spine combination together. So like I said, the ART retractions, lateral flexions, did not touch it. 3-month diaphragmatic breathing. I noticed he had like giant diastasis, reduced tone in his upper trap after doing that and his scalings, but he was like straining a lot, turning red as a cherry pepper, and basically just like sweating. This is literally just breathing. Like his legs are assisted, and he's doing all that. And he's like, yeah, I can feel like up in my like neck up here. I feel like I'm straining to breathe. So like I said, focused on his shoulder at this time, put him sidelined, had him roll around his shoulder. Trying to teach him basically how to use his shoulder independent of his T-spine and his neck. And after I did that, he stood up and he was like, yeah, I've got like 0 neck pain. And like all of his top tier movements, like all of them are just like basically clear now, except for the CT extension. Just said that already. And then we also did first position on that as well to finish it up, I believe. Yeah, first position. Trying to get him to have just thoracic extension as well built in there to maybe start getting again T-spine separate from shoulder, and then learning how to basically breathe like into diaphragm because he can feel a little bit better on his thighs when he gets to that position. That was basically the end of that first visit. I adjusted CT thoracic and first rib on the right side, and then homework first position 3-month breathing. So that was like a week. That was like a Friday. So then I followed up with him again on Monday. That'd be a second visit. 3 years later, came back in, 0 pain. Can't reproduce it except for palpation and trigger point and scalings. That kind of reproduce the same pain that he kind of feels. So now it's like no longer there's tone up there. It's actually like a little like nodule that you can like palpate and like push on, and it like recreates the symptoms that he had felt before. So I adjust the same things as before. He crushes homework, but he still finds it hard to do breathing and supine. Treatment, we did 3-month breathing again, taught him how to do IAP with legs assisted, and then 5-month sideline, which he was able to do that just fine. And then I taught him low oblique rotations to start kind of rotating around that shoulder in a propped up position, which he found tough, but he could do kind of well with just like different cueing. So homework, I sent him home again with 3-month breathing, instrumental pressure, low oblique rotations. So I was supposed to follow up with him on, I guess today. I saw that he made an appointment for Wednesday. This would be 2 days later, and I was like, this can't be good. He didn't cancel the days. He just made one for the middle of the week, and I was like, that's never a good sign. So I walk in the room, and this man is basically cranked into right lateral flexion, has to use his whole body in order to be able to move. I mean, he goes, I couldn't sleep the entire night. He was like, I tried. The only thing that got him through the night was the actual, like, just 5-month side rolling that we had done in there. Not the actual, like, rotations, but just, like, laying on his shoulder, kind of pressing into the ground and just, like, rolling around a little bit. He goes, that pretty much took my pain away. And then it would come back probably, like, 5 or 10 minutes later, just, like, a really big, like, spasm. And it would just, like, hang on. He goes, I probably did 200 of those things on my shoulder. And I was like, all right, well, you're the first person that's ever done that many of those. So we're going to basically put a sticker on that and say, like, you passed. But he said he started feeling it after he did some of those low oblique rotations the night after we got through I guess it would be like Monday night. Yeah, after he saw me. He traveled the next day for work, and he started feeling it again in his upper traffic. He was carrying mannequins to his car. And like I said, he's a pretty big dude. So he's like, these mannequins normally aren't really too heavy for me to carry. But he goes, I had to set it down once or twice on the way to the car because I felt like my upper traffic was just getting worked the entire time. I kind of started feeling it down out to the like outer portion of my shoulder. I was like, all right, perfect. So here's mistake number one. One, I sent him home with low oblique rotations. I think that might have been a little too high level considering he was still sweating just doing the breathing. And then I know he was able to do the rotations, but I think it might have been too tough for him if it took a little bit of cueing while we were in office.
Low oblique rotations,
yeah,
fine now.
the low oblique rotations. Because it took a little bit of cueing, but I think there's just a disconnect whenever patients get sent home, in my opinion, at least for him, at least for like a couple hours later. If it was like that tough for him to use his shoulder. Does that make sense?
Mm-hmm.
Okay. And then let's see, what else was it? And the other thing is I basically was just like, let's just kind of run through your neck exam again while we're here just to make sure I didn't miss anything in the neck since we attacked your shoulder, got better, but then it started like came back like with a vengeance, I guess, this next time. So I redid the neurological tension. So this is like radial, median, ulnar, all of those. He only gets pain if you slack both ends at the same time. And I mean, like that lights him up like a freight train. So if I tension him fully, he gets no pain. If I just like slack his head, no pain. If I slack his arm, I get nothing. But if I slack his head and arm together, like it just like, he's like, yeah, that spasm just starts up immediate and it just like holds on, like won't let go for probably like 5 or 10 seconds. He doesn't get any shooting pain. It's just like local always to like right here, like a kind of like front and like back side of the like upper trap area. So yeah, so again, this differential basically came out neuroforaminal encroachment maybe to like sliding dysfunction, which we had talked about. Brachial plexus irritation again, which I think could still be like our biggest player again through the scanning because there's such like tone again through there this next time he comes in, and also just the trigger points that are in the area. So this time did retractions for CT extension, and that took away the like sliding dysfunction on the neurological tests, but yeah, that was pretty much it. Like I wouldn't say that it really cleared anything like in terms of maybe like a extension restriction or anything like that he had, but yeah. So then we redid the 3-month breathing, and this time I just kind of had his right arm out to the side, which resisted like abduction. Has no pain again in his like neck or shoulder. And then we foam rolled his T-spine. So yeah, that's kind of where we're at. So I don't know, it's kind of that's kind of where I'm at with this patient. I'm supposed to see him again today, but he's at the lake. So he didn't show up today, which I guess is a good thing because he said he was actually nervous about going to the lake. It's like his daughter's birthday or something like that. But yeah, so I guess I'm at the point where I'm like, I think his neck is the bigger component, or not his neck, like his shoulder is the bigger component in terms of just how he is using this whole, I guess, like upper extremity like complex on this right hand side, right? Like rib cage, neck, shoulder. Because he even mentioned, and I think this third visit, he goes, I feel like whenever I look to my left or my right, he goes, I feel like I have to bring my right shoulder with me in order to do it. He's like, if I take my head over to the left, he's like, I feel like I have to bring my right shoulder up with me. But if I go to the right, he's like, my left shoulder doesn't move. So I think it's just like he's almost just developed this pattern, like a protective pattern, one from maybe the shoulder surgery that he had and just maybe not using it properly to where he's just like, my shoulder works with my neck and my shoulder and my T-spine work together as one unit instead of like separate entities. So that's kind of where I ended up with my patient. So I guess we'll find out the next time he comes in how much he's progressed since then.
So what's maybe one of the first things you start thinking when somebody has, I mean, every cervical test, multi-segmental extension, upper extremity pattern 1 and 2, we're all creating pain in the exact same area. Like what's something that should be on your radar?
Disc herniations.
Central sensitization, so like a bunch of movements create the same exact pain, which brings the likelihood of kind of your ultimate maybe hypothesis into play. But then in that hypothesis, you're like, well, I think he maybe uses it. I would say you're like, he uses it one. I would think you're saying, well, there's some dysfunction that lies there. There's two things that I think are left unexplored here. And you mentioned a little bit of like using improved upward rotation of shoulder blade, like how do shoulder blades actually move? You know, like flexion of abduction tests. You know, looking at how his, you know, glenohumeral rhythm is with the shoulder blade, 4-point rocker, like actually look at like what the difference is there.
I did actually look at his upward rotation bilaterally, and his, I would say there's like a huge difference in my opinion side to side, except for his right upper trap just like helps like bring the shoulder blade up, if that makes sense. So like versus the left, like the left and right scapulas like move at the same time and travel the same distance. It's just the right upper trap has to like kick on for him to go like that way.
Which brings me to my next point of, you know, when you're new in the exam game, you don't get to skip steps. One of those steps is what in your neurologic exam is reflexes, right? And in this scenario, reflexes could be huge because if you have surgery around your shoulder, altered motor, you know, programming for that long, the alteration of the DTRs could kind of tell you something's going on, and also, you know, help rule out something, but also tell you if you're going to have long-term change, but also what's one of the nerves that's going to help innervate your upper trap. Accessory nerve, which is a cranial nerve, what's the only thing that didn't clear out from the movement? CT extension or extension, the cervical extension. So then kind of playing into all this is, you know, he's like, I feel like I can't, you know, turn my head without moving my shoulder. In particular, when you have like nerve irritation, especially, you know, that's, and you went through an exam, like making sure, well, is that extension restriction purely CT, right? Because you have some like OA extension, you know, stuff, occipital glide, you know, things like a Shinzu reflex, really karate chopping its trap and seeing like what that response is that pathologic, because he also came in an antalgic position.
No, he doesn't have that. I did that.
Yeah. So like there's just a couple things where you're like, okay, the chronicity of it could change it completely, where it's completely centrally provocated now, and he shows up with a bunch of different stuff. But what reason I'm saying that everything changes. You know, shoulder range motion changes, cervical range motion changes, like pain changes when he loads his shoulder. I mean, that's not mechanical, that's neurologic, right? And we know, you know, everything's at the end of the day neurologic, but I think there's something to make sure that you're checking boxes, like, you know, there's no pathologic reflexes. Could you have some sort of cranial nerve irritation? Because the spinal accessory nerve is weird, right? That it does dive in the muscle, and goes to your upper cervical spine. And I mean, so just looking at all that stuff, I don't think you missed anything. Sounds like, you know, kind of tough case, but I'd say you're on the path, like global dysfunction around that right side, you know, rib cage, scapula, glenohumeral joint. But maybe there's some specifics with like how those are playing together. They're just bugging the snot out of like a cranial nerve or, you know, something like that. Yeah. Which again, right in that spot, I'm not saying that's a pain generator, but that may be a big cause of why he's altering motor patterns like that.
Which one is
the other reason I say it is why blood pressure, like I don't know, just got a lot of things that can play in autonomic nervous system, you know, precursors. Sorry, what were you gonna say?
Respiration centers of the brainstem, pons, medulla.
Pons, yeah. I mean, there's two different regulatory centers. I mean, for the most part, I mean the pons, but yeah. And I'm just saying, you can get upregulation all over the place, and then yeah.
I'm just thinking of like what level, like potentially the brainstem, right? Like he's having that hard of trouble just like breathing. Like, I mean, like I literally taught him how to do intra-abdominal pressure with leg assisted, like holding his legs up like he's got those rested on my legs. He doesn't have to do anything except just create pressure. And I mean, he gets it from the table, like dripping sweat.
Yeah. He's on 3 blood pressure medications for a reason. Maybe some of that's familial, maybe a lot of it's behavioral. I mean, there's a lot of blood pressure stuff, probably anxiety, breathing driven, especially if it's a situational scenario. It's crazy. He's on through how old is 50s? I'm
47.
Yeah.
Which again, like kind of did the breathing side of it, just because he's on ADHD and I just asked him like, what are you on that for? And he's like, I just have a stressful life, man, because I can't get anything done. I was like, take that. Which again maybe ties to maybe just how he breathes up here. Like I literally, oh, that was the other thing that was I asked him to take a couple of deep breaths. And I told him to take some deep breaths and recreate his pain as well.
I mean, right there is like probably your biggest finding because of secondary respiration muscles and like what can create pain there, but also ruling in again some things that like would just be a bit offshoot from just pure, not pure musculoskeletal, some musculoskeletal, but a little bit different than you normally see. I'd actually like that maybe a really good pain audit up front. It's like, hey, we gotta clear that before we expect anything else to change. Because there's a lot of stuff that's painful. Right. Cool. Anything else?
Yeah, sometimes that has some.
So when you, like in a case like this, it seems like there was a lot of different things to like pick from as far as audit wise, like you had a lot of different findings all across the board. What kind of goes through your head or what's your process of like figuring out what you want to, put as your audits? Cause there's like a big host of things that you could pick, but what do you kind of think about when it comes to, hey, I want to really hone in on this?
Yeah. I guess the biggest one is so like the cervical, I didn't really choose those as like my pain audits necessarily. I mean, I guess I could have. I used more so the orthos of his neck. Besides just like the movements of them because I couldn't reproduce them unless they were active. So I guess that's kind of why I chose my pain audits as like something that I could reproduce that were more objective than me like passively or actively doing it. I guess if that makes sense. The functional audits, I did those because could I affect somewhere else and it affect his neck? So like I ran through the whole neck process and he was really thinking like it was his neck. Like had been told, he had, things that were misaligned, things like that. So the functional audit for me, I guess, came later in that whole process, just because I was trying for like his sake, just to rule out that like it wasn't like his neck specifically. And then once I saw that I could actually like shoulder range of motion is pretty terrible, right? But then I'm also thinking like he had neck pain before, it was gone after he had his shoulder, so it's kind of like, are both of these things like, are they maybe like intertwined?
Yeah,
like, it just seemed very different that like he had neck pain, shoulder surgery, neck pain went away. Now he has a shoulder that doesn't work properly, almost like he needed to have surgery again type thing.
Yeah.
Neck pain again. I do something with his shoulder, range of motion increases, neck pain is like completely gone. Like he comes in like 10 out of 10 pain and leaves at like a 1 of like dull achy like.
Yeah.
So my functional audit was just like I affected his shoulder. Like that just seemed like such a big glaring asymmetry. Like that's what I'm trying to do for mine is like what's the biggest like glaring asymmetry? If like everything the cervical spine pops up as being painful, like that to me doesn't seem like necessarily like just straight up asymmetry. It's like everything hurts. It's like that's not asymmetry. One side versus another being just like he couldn't do anything with his right arm over here.
Yeah.
But it was just like that was way different side to side. To me, that's where my functional audit came up, and I was like, I have to. There's no way for me with what he does as his job of like teaching, being a firefighter, having to reach for like the nozzle. Like I asked him about that, like reaching for like the nozzle, like his oxygen when he goes and stuff. And he's like, that's super tough for me to do. So it's just like I've got to get his shoulder, in my opinion, working better. Just one for just his functionality of daily life, and by going after that, it started clearing a whole lot of stuff that we needed to go after.
So in that scenario, I would use upper extremity pattern 1 as your pain audit then. Because it's the highest correlate, at least from what he said, to something that you like, dude, that is really tough and painful. Because then he's gonna draw from that way more often of like, ooh, it is better. Which if it's central sensitization of a chronic pain, like that's a really powerful thing. They're like, dude, I haven't thought about that in forever. And then he may still move like trash or shoulder, but he just end up pain with it.
Yeah, he said the way that he's been getting around it is he just like I said, he has tons of rotation, which maybe is how his body's adapted to it. Like, because I literally just throw my hips forward, rotate as far as I can, get my arm back, and like then I'm able to get to the actual like I'm actually able to get to the nozzle and stuff like that. So
Yeah.
I mean, if he hasn't been able to use his shoulders to do like his actual job in I guess over 2 years now,
Yeah.
it's to me that just seems like a bigger glaring asymmetry than
Yeah.
just how he moves his neck, in my opinion.
I think another, just because I was watching, another big piece like later on, like not directly through the history, but after working through your exam, you kind of figured out that after he had his surgeries, he never really had any proper rehab done to his shoulder too, right? That's a big piece too.
And again, it's like, could it be like scar tissue maybe that's over there that's maybe affecting how it moves? Like I can't tell all that. Like he has a pretty serious scar over here, but he said he did go to somebody who did work on this. He had scar work done, and he's like he used to push on that. He used to recreate a lot of pain, but it looks like it's healed pretty well, and I can push all over his scar that's there, and like it doesn't reproduce any pain. So I'm not too worried about that.
Can't remember yours.
Oh yeah. Yeah. So you said that you think you did too much maybe with him to send home with the low oblique rotations. Do you think you have to regress that when you see him again, or are you gonna just have him do that in office under your guidance and you just different at home?
But he was doing 5-month shoulder rolling. That's what gave him relief.
Well, the shoulder
Yeah,
rolling, like,
so I did shoulder rolling.
So that's kind of my question. Why did you give him low oblique rotations?
This after the second visit.
Yeah, like what was the thought process of the progression to that, first of all, before we think of why you regress back out of it?
So why did I give it to him?
Mhm.
Because I was trying to again, he was okay. So he's not able again to use like his shoulder, in my opinion, very well in correlation with like mid back. Let's just put it there. Low oblique rotations, I had him to challenge him a little bit more because even on the table he was like, I mean, he was kind of throwing me around. I'm not gonna lie. Like it made the exercise tougher. That way he could actually like feel what I was trying to go after through the rotation. But again, like his first thought was his shoulder basically just shot to his ear. So I gave him the cue of like pushing long from the table, and he got that pretty well. But maybe it was just there was a discrepancy because the third time he came back in, we went back over the first position and like kind of just I was like, I just want you to pull your shoulder blades, just create as much space between your ears and your shoulder. And he goes, oh, that's what I've been missing in a lot of my other exercises. So I guess like whenever he went home, he didn't think about where his shoulder was in relation to the ear. He said he started feeling it for that first time after he did that Monday night, which maybe just aggravated it. And the mannequin really just like sent it off.
I'm sorry to hijack your question, but this is where I would say the specificity of examination of like, well, how does the shoulder blade move? What, from both static, like where is it starting and where can it go in space? Because let's say you're going to use something like, that's a 7-month position. So in essence, what's really hard for most people doing that to not let their shoulder blade just crash into a massive adduction. So that would be why I would use that. Does it make sense? Like if he literally is like crashing an adduction and we progress enough, I'll be like, okay, now that's a progression. But you also said, well, he lives in the transverse plane. So then that's largely rotary motion, right? It's low oblique rotation. So then what I would say is like, and again, I have no clue what it is. Like if he lacked, abduction or upward rotation, that's the guiding like light to why you choose certain things, right? And we all kind of get caught in like, well, yeah, if the T-spine's got to move, you got to, you start with straight pair maybe because of that or start position. But then if you're thinking, okay, this guy lacks upward rotation, Well, literally using just a straight sprayer position, taking it out in the low barrier, right, and having starting to rock through low barrier creates upward rotation with thoracic spine uprighting, and now it's kind of like, you know, the beauty in like marrying those two things together, and then you just progress that out. Does that make sense? So I'm not saying you did anything wrong, but the positions themselves can then like just feed forward, and you're just like constantly working down the same path, which is, we won't say what we're working on in here, but as we work on some things that help guide other practitioners, that's kind of what we want them to be able to do. Is just have a clean path of like, hey, this is kind of where you're going, because so yeah, just be interesting if you maybe next visit, just, you know, maybe it is really good, but I would say most people we know that don't have post-operative rehab on shoulders, it's not the actual glenohumeral joint that's dysfunctional, right? Because that's the most mobile joint in your body. It's literally the scapulothoracic motion that locks up, right? Everybody's got this pattern, or it doesn't get here. And if we get their shoulder blade moving and then working in unison with the glenohumeral joint, like that's kind of the beauty of it. I mean, this guy's got up trap stuff. Everything around his shoulder hurts. This in particular is, you know, shoulder blade driven, right? Even though this is lacking. But you also said he got a decent amount of internal and external out of PIR, which also shows it's not capsule, it's not tissue, it's patterning. So that's what I might explore, is really in all patients, right? Like we don't have anybody take the shirt off and, you know, look at flexion abduction arcs and things like that. But in that scenario, 100%. Like if you're like, man, it's all over this, like, you know, take the shirt off and like, you know, do that, or at least through a t-shirt, put your hands on it and then put them in 4-point rock, or put them in straight sprayer and just have them move around without coaching them, right? Just see what they do. You're like, oh my God, like that's, you know, especially in fatigue. You have somebody do 20 reps as a 4-point rocker, and you've seen stuff normalized, right? Like we see something get better, you've seen something get worse. It could go both ways. Yeah.
I think I'm done. I took long enough.
You're good.
Cool. What was that flop?
I don't know. It's good.
We need after every case, instead of I have a gate gauge, we have a, what would we call it?
Flop gauge.
Case. Yeah, case gauge. I don't know. Let's think something.
Grumpy gauge.
Somewhere between the belly flop and a soccer player getting a yellow card.
I'm not a soccer fan, and
Oh, dude.
yeah,
Credit card? Yellow card is just like a slap on the hand. Like a slap on the water.
I get that.
Slap.
All right, 72-year-old male, presents with low back pain. Radicular pain is the right posterior thigh. Started a few weeks prior to me seeing him. Doesn't really know why. He's relatively active. Plays golf a couple times. Tries to play a couple times a week. And he is pretty active, not like in the gym sense, but does a morning mobility routine every day. He originally felt the pain radiate to the anterior aspect of his right thigh as well, but that has since gone away. And then he has a prior history of lumbar fusion at L4-5 and L5-S1, which I don't remember which. I think it was L5-S1 first in 2015, and then 2017 he had L4-5. But you've also treated him. So, and then he's had double knee replacements done in 2021, a couple months apart, which those honestly moved pretty well for his age, and haven't had them done recently. But yeah, so I had said that he did not remember when it started. After I asked him a few more questions, he goes, well, I was playing golf, and I remember hitting a few balls before I was playing, and it was like as I got into the higher clubs, the lower clubs, but once you're gonna hit them farther with, right? It was like 3-wood driver. He said it didn't bother me at all while I was hitting shorter, but then once I started going farther, I remember it started to catch, and that's when he felt it go down his thigh. And he's right-handed. So on exam, top tier, dysfunctional, non-painful, cervical extension, multi-segment rotation bilaterally, and then single leg stance bilaterally. Worst on his right though. Then dysfunctional, painful, multi-segmental flexion and extension. Didn't really put any functional non-painfuls because there weren't that many.
did he have preferred pain with flexion or extension?
No, well, So not in flexion, in extension, he had just pain in his low back. When I broke it out to stork on the left side, he had pain on the right thigh, or posterior thigh. So that's kind of where I'll go next. Orthos, stork on the left, like I said, reduced the right low back pain and radicular symptoms. Then straight leg raise gave the posterior thigh pain, not necessarily low back pain. And then on neuro, he had, now this is something that I've tried to I haven't treated a ton of people who were above 75. But the ones, I guess I've noticed the ones that typically have some kind of vibratory sense diminished. His was the same, he had loss on both sides. If I remember correctly, it was basically everything below it. So then ranges of motion, pretty much everything was limited. Cervical, thoracic, lumbar extension, lumbar flexion, knee flexion bilaterally, internal rotation bilaterally. Yeah. And then thus far, my pain audits were the straight leg raise and stork on the left side. And then functional audit, I had lumbar flexion and questioned the single leg stance on the right, just because it was worse than the left.
Lumbar flexion, like multi-segmental flexion,
Just lumbar flexion.
palpation.
Yeah. Which, again, kind of like you had mentioned with Seth's case, for that guy's neck, a lot of this guy's just doesn't move. So, he also had two level fusions. So, so as far as what I was going to be able to get back, I'm not certain. At this point, I was considering either central canal stenosis or lateral. That day, the only thing we did was McKenzie lumbar press ups, and which were centralizing his pain and decreasing the pain in the lumbar spine whenever he was going through the stork and all that. I was like, okay. So that's the only thing I sent him home with that day. Then second visit, I remembered at some point between his first and second visit, I remembered a conversation you and I had about stenosis and how initially they're probably going to respond well to extension, and then they're going to have to move into flexion.
That was my question. I had a question on that.
Mm-hmm.
If he had pain on some extension stuff,
yeah,
what made you go after extension still?
I'll be honest. I think it was because they were both painful, and I was like, well, I'm going to see if one does either of it, right? And then if not, I'll move laterally. And so he came back in and he goes, yeah, I felt better the first 2 or 3 days. Then I went to play golf. 4 strokes in was when he started to get that in his thigh again. And so I flipped and I went after flexion. And then as he reported back the next time, that was definitely better, right? So he had, in that visit, the pain had gone from posterior thigh kind of up to his glute, and it was less intense. So I sent him home, and we had done first position as well that day, but I just sent him home with the flexions, seated with him just pulling up to his ankles, because supine, there was no way he was grabbing his knees. So third visit, he comes in and again, the centralization from posterior thighs just kind of up in the glute has stayed, so it hasn't gone back down there. Then he says, yeah, the flexions helped for a couple of days, and then it seems like it just kind of stalled. All right, so then we went after, and now this is where I was also, as I revisited the case, I went, okay, should I have just gone longer with this and not change something? But I chose to go for that lateral component. We shifted him to the right, and again had some improvement during the visit that day. So I don't remember if it was when he was doing the stork that he wasn't getting the radicular symptoms anymore. That was kind of my main audit, so I was assuming that was where I was at. At this point, he had also started mentioning a shoulder thing, so we were trying to do both of those at the same time, which is where my fourth visit was mainly focused on the shoulder, which I think is coming from CT, T-spine. fifth visit, we get back to more of the lumbar stuff, which I've seen him 6 times at this point, and today was the 6th day. So last week, he again reports that there's slight improvement in the right posterior thigh. Mornings are still the worst. It gets progressively better throughout the day. Hadn't tried swinging a golf club. So this was actually the day that you were in there with me. And Tanner did a lot with Tuscaloosa VA this past, for the last 4 months or so in his preceptorship. And you guys did a ton of McKinsey as far as intervention, but also just that whole assessment, right? And so I let him take my patient through all of these different standing lumbar extension with overpressure, lateral flexion with extension, and none of them reproduced the radicular symptoms. So that was when we had all the stuff written on the board. We came in afterwards, and Tanner was like, well, I don't necessarily think that it's stenosis in the sense of, if it were stenosis, then those radicular symptoms would have been provoked with the prolonged staying in that position. But could fall in the category of derangement or mechanically inclusive of those 5 categories we were talking about.
Can we pause right there? This bro Daniels had a fusion at L4, L5, and L5S1, right? And we're thinking he's having sciatic nerve like derivation of radiculopathy. And then we're going to use McKinsey. He does have a derangement. It's called pedicle screws. I'm like throwing this out there, and this, I don't know what the conclusion of the case is, which we're really at, or the conclusion as of today. It's very interesting if we're mitigating pain at all, aiming anything that's fine at that level. You ain't getting any movement in there.
Yeah,
it's fused. It's a very interesting thought that you're like, we kind of changed stuff when you talk about centralization with extensions, and it kind of like plateaued. That's extremely interesting because, again, there's still a neurodynamic component with a contiguous nervous system and all that stuff, which then raises the question, which would be Michael Shaplok's question from neurodynamics with extension. If we were doing things to the nerve root, his idea would be you're actually going to create more compression with extension. That would be not good. Or are you actually tensioning things and moving the nervous system around through the fascia along with it? But I'll let you go ahead and finish, and then we'll talk about that more.
Okay.
I'm scared. Just kidding. It's interesting though.
Yeah. So then I done a treatment for the 5th day.
You did.
No,
We didn't.
we changed anything different that day? We stayed the course of lateral. Today I must have, because today that's kind of where I kept going. I loaded in the lateral sense with that banded lateral flexion. We tried going through a suitcase carry, and then neither one of them changed the distort much. So I was like, okay, well, we'll go back to something flexion based. We went through a few Jefferson curls. I took him through his bilateral sciatic nerve flossing on the table, and that improved. Like, he had no particular pain in the distort.
Ding ding.
What'd you go?
That was after Jefferson curl and bilateral sciatic nerve flossing.
Aimed at like lower spinal cord mechanics, basically.
Yeah. So I sent him home with those nerve flosses, just up against the wall. So that was today. That was last week.
Interesting. I mean, that last little part is kind of where I was heading with it. It's like, so what I'm putting in here, and if anybody listening to this, watching this does have, I mean, by the time you get a hold of me, I'll have the information, but I mean, I'll be looking through research of lumbar fusion in McKinsey, right? And seeing like, because again, McKinsey's been in this mist since Robin McKinsey first proposed the DISC model, then moved away from the DISC model to a derangement dysfunction, postural syndrome, to, that kind of still not, it's not largely understood. I mean, they even say that on the website, right? But the mechanism of action still have reproducible outcomes, so that's why people still use it. But in that scenario in particular, the fact that you're moving them multiple planes of motion, because now you have to think the lateral component, you're moving the nervous system right through there. So like, this is, and I'm not going to put words in Shaplok's mouth, or he doesn't think that McKinsey has anything to do with the afferent stimulus into a joint mechanism around the spine, which we know that's the most densely, populated mechanoreceptors in your body, besides cervical spine. But like, very interesting that even if you would have just kept going one way, right? You don't change it to this now. What would happen over time is still lateral component or moving stuff around, but yeah, I don't know. It's hard to put any of us in other shoes, but it's like as soon as somebody tells me I have a double level fusion and they're having radicular symptoms from one of those levels, I'm immediately like, well, wait a minute, that has to be something completely different. Unilateral, right? Bilateral, yeah, you can still have central canal stenosis that progresses with fusion for sure. You can still have lateral foraminal stenosis that progresses. But if it's transient, which it is, I mean, that's like how in the world besides, neurodynamics. So what else did you try? I'm just curious. Did you try just static openers or anything?
That's usually where I start before I.
Which again, there's nothing to open at that level other than pulling it, the nerve through the neuroforamen a little bit or something. So I'm just curious if that caused symptoms or no change.
It must not have. If I didn't write it down, it must not have done much.
Yeah.
Or at least that's what led me to go towards the lateral shifts.
It's interesting.
Yeah.
Slump with negative, all that. So straight leg raise and stork.
Yeah.
Which right there, right? Two different sides of the spectrum, right? Loading what we would say stork is doing is what? It's loading a set, right? Or loading
like the opposite.
Yeah, with rotation. So yeah, as you left leg, right, you're getting, rotation into the contralateral side with extension would be the thought process.
Yeah.
But again, that joint ain't moving. And you're moving above and below, which then again, if contiguous nervous system, you can still pull stuff around. And let's say you had IVF encroachment of the level, who's to say that you're not trying to tug that nerve through an IVF that can't move? Yeah. That's not going to be transient, in my opinion, at that point, if you have that much encroachment. That's interesting. You have to think about it more.
Yeah, and that's he would bring up a few times, like I think trying to get me to see if it was more of a hamstring thing, and that's why I was like, hey man, you had nothing in your mechanism of injury that tells me to strain your hamstring,
and no hip findings, no like posterior labrum. So yeah,
well actually he has good external rotation, but nothing like that would produce his. No bruising, no tenderness attached. And I was like, it was when you're swinging a golf club. Like he felt it at the end of the swing when he's leaning into that side.
It's interesting.
A question I have about your like initial audits and stuff, something that I kind of like to utilize as leverage, and we talked about it with the firefighter too. If this guy's a golfer, and you kind of have a couple of top tier findings, when do you reconcile like using the top tiers findings or like mimicking a golf swing, for example?
I actually had to do that.
You had him do it?
I just didn't write it down. Yeah, I would have him do it. I don't think I did it with the club out here, but I would just have him do it.
Yeah.
Especially too, like if it's something that's been lingering for a while and somebody's kind of like hesitant towards a certain movement, just like that graded exposure back into it, and then you have a good test that is something that they care about. I think it's pretty big.
No abdominal surgeries, not like that.
No, I think it was just the knees and the infusions.
So again, just this is why we do this too. It's not just for people listening. You even said like, well, I don't know how much I'm going to get out of lumbar flexion. So that is a functional audit may not be a strong way to gauge like your success outside of pain, in particular if the pain is a really weird pain generation or something that may be hard to change if we think it is truly neurologic from an area that has no movement. So in that scenario, just because of the fusion, I'm not saying anything or that, like I would pick a different audit because I think you're going to be like hard pressed to like then go back and be like, oh, I'm actually making change if his symptoms aren't changing.
Yeah.
And again, in this scenario, I don't know what that is. Like if everything moves that poorly and you're going through and you're like, what are correlates to that? Well, if his, mechanism of pain outside of our test is golf swing, well, where else does he have to get extension? That scenario is T-spine and his hip, right? So like make sure those are present. If one of those isn't present, that comes higher on my list just because of that. Yeah, you know what I mean? Kind of tying almost where you're marrying your pain audit and your functional audit, like he has pain in this movement, so maybe I use something around that, right? Is my pain audit, or stroke test, which I think is your best pain audit for sure. And then kind of like go into what would be a necessitating thing to offload the pain audit from a functional standpoint. T-spine extension, hip extension, ankle dorsiflexion, right? Like any of those that like could be manifesting with pain. Yeah, and I think that's a good idea in general. It's not always that you could, but like you should be able to explain why. I mean, that's a treatment focus, right? So maybe even though you're treatment focused, you're on your functional audit. But like, well, what am I going after besides pain alleviation?
I guess it's hard for me whenever it's people like that are super stiff.
Well, that's what I'm saying.
It's like, whoa.
Yeah, that's what I'm saying.
I don't expect a change.
Well, I think you got to set yourself up for a surprise, because if they're stiff all over, I mean, you honestly may have huge change. Yeah. So that's where, again, like if there's bilateral stiffness everywhere around the horn, like, yeah, it gets tougher, but like if they don't have what you're supposed to have, like they need to have some adequate. If he has 0 hip extension bilateral and prone, give him 5 degrees, see what happens. You know what I mean? Maybe offloads his lumbar spine in general enough. Because what's the most provocating thing for somebody with stenosis? Yeah, like hip extension, right? Yeah. So let's make sure they got that. And then where they, multi-segmental extension, which is stored, where they need to get T-spine and hip, right?
Which I don't remember. I know I would have checked hip extension the first day. I'll check it again. It must not have been that bad. I know it's T-spine extension. Not good.
Yeah. And then in that scenario, kind of like your case breaking down into the estimated breakouts of like, well, if stork is positive, like I always check prone hip extension to make sure, well, is left hip extension and create right low back pain? Yeah. Because then if that creates pain, it's not going to be a functional audit because that's wrapped up in that. So it may have to be like T-spine extension or ankle dorsiflexion or something a little further away, or even tone or local joint restriction T-spine or something.
And if he's got that was quiet for a while. Take his voice back. If he's still playing golf, like that's where was until the pain came on. But like that's where I feel like I think like lumbar lock breakout would be pretty beneficial, or just like him sitting on the table, because if his lumbar's fused, I mean it's pretty much blocked already. So if he didn't have him seat at the table, sit on the end, right, just rotate side to side, like does he even have just like adequate T-spine rotation? And if like that would just have like another thing that you could like maybe go after of if he's still wanting to do a rotational sport, like that way he doesn't maybe chew up his hip later on down the road. You're kind of going after both. Because maybe it is both, I don't know.
Yeah. Because in that scenario, what I was kind of getting at without, leading you too much, especially if you're doing bilateral cytocrossing, like get away from spinal cord mechanics. I mean, the nerve is still passing through, a bunch of muscle down your leg. So we think neurodynamics doesn't stop the spine, right? So what if he is just retching on it through his leg because he lacks rotation? And he already has joints that don't move well because they're fused. And then your job does become give him a bunch of rotation so he doesn't have to like get to the end ranges and pull around his head a lot, or wherever he can get it from. Like that would be interesting to break out for sure. And I know the question would be, well, why was the multi-segmental rotation painful?
And probably came from
right. Yeah. But you have some velocity and momentum to it. I mean, good enough time, bigger club, right? You put a weight out in front of you. Yeah. Now you can rip into it and kind of push yourself where you can't go without that. So I think that could be a huge key, like the longer club, right? And he's like, yeah, and smaller shots, very controlled, right? Nothing. Get a big old driver and got to control what he can't. Or it puts him, like I said, active, passive gap. Yeah, be interesting.
Whole deceleration for acceleration.
Yeah. Yeah, in that scenario, like I said, check out T-spine rotation and hip extension. And make sure, just start working function. Be like, yeah, pain may, like in that scenario, let's say pain just like keeps jumping around. I would 100% explain to the patient, like, to get your pain to go away, I don't think we're gonna have a symptom reliever. Like we have to change function, which everybody would do. Some people would have a pain alleviating thing, and then you get to change function. That's a great thing because like they're bought in. Some people you have to have a tough combo of like, dude, you're not gonna get out of pain until we can change this.
That's what we had. Beginning of our visit there, we had more conversation about that because he said that he was going to go get an MRI. And I asked him, I'm like, well, why do you want to get an MRI? And he said, well, I just want to figure out what's causing the pain. And I said, well, it's kind of why we do an exam and see if I said, if I needed to get an image, I would be doing so to think, okay, it's going to match whatever I'm expecting or what I've seen in the exam.
But his question back to you should be, what do you think is causing the pain?
And that's what we kind of walked through because at that point I was still thinking, well, no. We had already talked about the whole stenosis thing. And so I said, we've kind of ruled that out as being the true pain generator because it's not staying there whenever I put you in this position, right? It changes, it's transient.
Mm-hmm.
But I mentioned that not that he knows what derangement or can't think of lucid means, but I was like, we can change it based on how we move you. So it's not that this would, and I said, even if you had stenosis, like, would we go in there and have surgery to get it done? You get it cleaned out because you're not having, motor deficits or anything that is alarming enough. That it's just, I know the pain's real, but so he's also been seeing a pain doc for like 6 to 8 years. And she goes, yeah, that guy's had MRIs of my back for like forever, and I was just gonna get him, compare them.
Mm-hmm.
And I think he's going to get in mind, but I advised against it.
But my thing would be, if I was him, I wouldn't believe you either. I would take what Tanner said of, he was golfing. I'm guessing that's one of the things he likes to do the most, right?
Mm-hmm.
That's when he also had pain. Then have we broken him out? And I'm not saying it's true because we don't know. And you're like, yeah, the things that you need to be able to do to golf do not exist. So then we have to presume that when you go golf, you put yourself in a position that you can't naturally get in unless you swing a heavy club out in front of yourself. Because again, you have to walk somebody down the path of, they have no clue what we're talking about when they're like, well, no, your pain's not coming from here, MRI doesn't show it, it's how we move your back. My next question for you would be like, so when you move my back, it gets better, how are you moving those fused areas? Would be like my next point.
Mm-hmm.
And then you'd be like, how to explain it? You wouldn't. So that's what I'm saying. Like, you got to make sure you explore around that. And that's why that fusion popped out like right away of like, well, wait a minute, what are we doing? I'm not saying we understand the mechanism of McKinsey because obviously stuff's changing, but that's where like we have to in our heads write the functional pathway of like, just like Seth's patient, like what do we not just, yeah, like Seth, I think is like Seth's got like his heat seeker on the area, then it's like, well, what exactly, right, should we be working on? There's a couple things. Rib depression helps it, like, doing some stuff helps a bunch of stuff, but like what's the driver there? Right. And a lot of this could be central mediated. It's like guys been going to a pain guy for 6 to 8 years. You got, central sensitivity that you just move a bunch and like you're provocating pain that has no mechanical bearing. But then our job becomes what? Get them to move better elsewhere, because that's how you increase central sensitivity. So it leads you right back to the same thing. Even if you don't write the biomechanical model and you write the pain science model, they play in the same path. But I think too often we don't like acknowledge both. It's like you move like this, so it's better, or I think both of those are central sensitivity driven, big time. But everything is after 3 months. And what is it? 80% of pain after 3 months is supposed to be centrally mediated, and that's like how many of our patients? Over 80% of our patients probably 3-month-old complaints. Mm-hmm. My patient day with a knee complaint in 16 months. Trying to explain to her, I know you've had these, MRI findings and bone contusion and all that stuff, and like trying to explain to her, like, I get that you might have that. I don't think that's what's creating your pain, even if you have that thing on an MRI. You still got to rule it out. You can't just play that game with bone injuries. But at the same token, I got to be like, well, why would that pain occur? You know what I mean? And I can't just tell her like, it's pain. Right, and I mean, she was an interesting client to work with. She goes through low back stuff, and I'm like, better or worse, better, or sorry, same. Okay, that's fine. It's like she like felt like she had to have some change, and it's like, no, we're ruling stuff out, so we kind of get down to your pain's being generated based on how you move, and we're gonna, you know, try to improve or change or create some novelty to your movement to change your pain. And then long term is changing that movement, you know, applying strength or something, a different motor control strategy. Did that guy have dysfunctional non-painful rotation? Yeah. Yeah, just a pure SMA breakout could give you like a bunch of starting points.
Oh yeah.
Right, but hip, T-spine, you know, like we talked about the other day in our, you know, the hierarchy from VNS and SMA is where would you start with that guy if you didn't know where to start? The cervical spine. Keep breathing, because the developmental kinesiological cycle is going to say what? The normalization of movement comes from what? Breathing, eye movement, cervical spine, thoracic spine, and then you start uprighting from there. So that's literally written into, you know, business of movement. As he says in that book, verbatim, if you didn't know where to start, this would be a good roadmap. So if you had somebody that, we just said this, if somebody was all dysfunctional painful, all dysfunctional non-painful, there's hierarchy, right? Rotation, single leg stance, but in his book, he actually rewrites that and says, no, let's follow the developmental kinesiological cycle, and it would be cervical spine first, which I would put breathing ahead of that. They don't. The cervical spine, because if you can't rotate your neck, you ain't going where your eyes can't go. I'm not saying that's where you would start, but if you were completely lost, you could. And the reason they also do that is why it's safe. Right, if it's dysfunctional and painful and it's way far away from the site of pain, you're not going to create more pain. In particular, if it's centrally provocated. You're just playing this game now. That's a lot of maybe visits you got to buy yourself.
But I was like, yeah, I feel like if I was going to do that, I would have done it early.
100%.
Yeah.
Which is both. And I'm not, you know, beating you up, but that's what all of us are guilty of, is jumping in too fast. And it takes us 3 visits. Had we had the like wherewithal to lay it out, those are the patient like experiences where you're just, this is the easiest patient I've ever had. Because you were on it from the beginning, you laid out the roadmap, they were with you the whole time, and you're just like, dude, this is working out like I thought. Not because you got lucky, you figured it out sooner, maybe because it was an easier case, or you just happened upon the finding that mattered most. Does that make sense? Like, I think the people we're not lucky, you're just like, God, I really just like laid it out. Even if it doesn't go like you think, but you get 10 visits in, you still had success. You know, like, it took me a couple more, but what I thought was going to happen kind of happened. Better or worse, you know. I'm cool. I'm still on that cheap Zoom plan. I think we gotta get off this one.
Do we have what is it? What the wins and losses of the year?
Let's hit him quick. Stack shooters. Lightning round. Tanner.
Okay.
Wins and
Your
losses.
win of the week and your loss of the week.
Okay.
Well, we haven't
Let's
run the race yet.
Yeah.
That's gonna be my loss.
That might be kind of tough. My loss for the week is Birmingham traffic on 280. I've never lived in a place that's had like stop and go traffic, so I'm still kind of getting used to that. This is only my 2nd week here. And then my win for the week probably happened like maybe an hour and a half ago, when I saw Seth Graham hit a side posture adjustment from the top rope. We got him a little box to go up underneath this table, so now he's able to thoroughly pounce.
I've got this.
Yeah, to his credit.
I've got Beau's old table, and it's non-adjustable. It's
like,
a nice table. I'm very thankful for it, right? Like, I'm allowed to practice because that's something that patients can lay on besides the floor. And he's like, yeah, it worked just fine for me. I'm like, yeah, we've also got like 5-6 inches on it. So like, some of these patients that come in, I mean, like, I put them side posture, they're already sitting like xiphoid prostate. So it's like creating space. I just got a little 2-step.
You have to get really good with kick pulls too. Maybe
Torch
that's table
will drop.
Yeah.
That torch
Take
did drop.
your training ground for that. I like it. What do you got?
Let's see what's in here.
My car finally got fixed. For now.
So if you don't know, very short, long story, Alex, totaled his car not too long ago, and then got a new car. Since he's had a new car, it's been in the shop more than my car has ever been in the shop. Ever. So
He torched the tire on the interstate.
really
like,
bottom of his car off.
I did, yeah, a tire went under my car, not my
Meaning
tire.
you torched a tire.
Not my tire came
You
off.
torched a tire.
So that's the win. The Honda's rolling pristine, right?
Yeah,
She's rolling on all fours.
the loss, I don't know, man, there's several.
Good for me.
Charlie Brown.
I lost his book.
We did hide his book from him, man.
That is pretty severe.
Nothing to do with that.
Other than just like whenever my teeth got kicked throughout the week.
Yeah.
Current loss, it won't be a loss, but
He's gonna go find out if that guy can rotate or not. That's
Yeah.
it. What you got, Seth?
Let's see, one of the week. We got these beautiful burgers. That was pretty solid.
It was really good.
I'd say maybe a loss of the week is you asked about snacks that we could keep making. And he said no to Oreos.
And what else was it? Ice cream?
I said Jenny's ice cream.
Yeah.
But he wasn't opposed to Alex's meat bar, whatever
No,
the heck that.
Adamantly opposed to calling them meatballs.
Okay.
I'm okay with having meat sticks, meat jerky.
Meat bar.
Yeah, if you, yeah.
If you know what that is, please.
you guys know good.
I
well,
know what he meant.
beef jerky is longer and thinner. The sticks look like a Slim Jim. What do you call an epic bar?
Bar.
Uh-huh. Uh-huh.
Yeah.
I don't know. Call it this.
Is it an epic bar on the wrapper?
Yeah, it's an epic bar.
Is it?
Yeah.
Yeah, I don't know. I thought that was like
Yeah. My win and loss are the exact same event, which I think was last.
Hot dog. It's an epic bar.
No, hot dog.
it's just an epic dash bar.
Mm-hmm.
Yeah, it's an epic bar.
Mhm.
Shit. But it's called an epic bar because they know that calling it a meat bar would not sell.
Yeah,
No, they just gotta have their name.
Mine has nothing to do with clinic. My daughter lost her effing mind the other night, which was a giant loss because it's just feel like you don't know what you're doing as a parent. The win was stuck to our guns, locked her in her room all night. No, not really. Just made her sleep in her bed all night. So for anybody parent out there, she woke up, she was like an angel the next morning. So sometimes when you feel like you're torturing your kid and punishing them, it's the best thing for them. Just remember that. See ya.